So, good morning, classmate. Our topic is about systemic inflammatory response syndrome or SIRS. So, what is SIRS? SIRS is a clinical syndrome that is associated with infection and also non-infectious causes such as autoimmune disorders, burns, and surgery. When a patient presents with positive SIRS criteria, it is important to begin searching for source of infection since the progression of that infection could lead to things such as sepsis and septic shock. For the statistics, according to Chirpek et al., during admissions, it is showed that 68% hospital admissions met SIRS criteria, 28% developed sepsis, 18% developed severe sepsis, and 4% developed septic shock. And for those at risk, very young people and elderly people, anyone who has had a transplant, people who are being treated with chemotherapy drugs or radiation, people with long-standing diabetes, AIDS or cirrhosis, someone who has very large burns or severe injuries, and people with an infection such as pneumonia, meningitis, cellulitis, and urinary tract infection, and ruptured appendix. So, in order to consider positive for SIRS, you need to have met 2 or more out of the 4 SIRS criteria, and it will be further discussed by Mr. Rivera.
Hello, I am Mark Joshua Rivera, and I'm going to present the signs and symptoms, the pathophysiology, and the management for SIRS. So when we talk about signs and symptoms of SIRS, so we have to meet these certain criteria. So dapat ada iti 2 or more symptoms mo kanagitoy. So first, we have temperature, less than 36 degrees Celsius, which is in medical term, hypothermia, or greater than 38 degrees Celsius, which is in medical term, hyperthermia. And next, we have heart rate, greater than 90 beats per minute. So, di ba iti tachycardia ket 100 beats per minute lang, ay 100 beats per minute. Immediate SIRS ket adi 90 beats per minute, iti cut-off point na para di criteria iti SIRS. So next, we have the respiratory rate. We have greater than 20 cycles per minute, or a partial pressure of carbon dioxide of less than 32 mmHg. Di ba iti i-exhale tayo kay carbon dioxide? So no napaspas ka nga gaanges, which is greater than 20 cycles per minute, so ado iti iwawar mo nga CO2. So that would result in decreased in partial pressure of carbon dioxide. So next, we have the white blood cells. Less than 4,000 white blood cells per microliter, or greater than 12,000 white blood cells per microliter, and a greater than 10% bands. So at a greater than 12,000 white blood cells per microliter, so think of it this way. So laban agiti white blood cells tayo against agita infection, that would result jay pangato iti white blood cells. Then at a less than 4,000 white blood cells, so this is more dangerous. Kasi whatever infective material such as bacteria, viruses in our body, that is winning the battle. So that causes the white blood cells to decrease. And we have the greater than 10% bands. So ano ba ito? 10% bands. So this bands is a young and immature white blood cells. And since ato unay ato yung 10% bands, agito itata iti manglaban ka naging viruses that is inside our body. So mga dangata no agit ti ilaban to iti infection kay young and immature white blood cells, diba? So but it is better to have something to be able to fight this war against infection. Now let's move on to pathophysiology. So kapag na kay we have infectious like viruses, bacteria, or fungi. Then we have the non-infectious, so trauma, surgery, or burns. So, once na yung that napuuran, surgery dito bagi, viruses or bacteria in our body, it releases molecules such as endotoxins, exotoxins, can teichoic acid. So agit ay bacterial toxins. Now it releases the inflammatory mediator. So mediators of inflammations are regulatory molecules that control the generation and maintenance and resolution of this response, which is triggered after recognition of infection or injury. Then cytokines. So cytokines are regulators of host responses to infection, so that the alveolar response, that the inflammation and trauma. But in unfavorable cases, this leads to an established cascade in which the innate immune response involving the pro-inflammatory cytokines such as IL-1 and TFN, interleukin-1, and tumor necrosis factor are pro-inflammatory cytokines, and when they are administered to humans, they produce yun, fever, inflammation, tapos tissue destructions, and in some cases, shock and death. Then yun, systemic inflammatory response syndrome. Now let's move on to the management. So the key of management is early recognition of the condition. So treatment should be focused on possible causes of SIRS. Like for example, appropriate treatment of acute myocardial infarction will differ from the treatment of community acquired pneumonia or pancreatitis, etc. So medications, so we have medical management. Medications target specific diagnosis for existing comorbidities and prophylaxis regimens for prevention of complications. So we have antibiotics. Because of increasing bacterial resistance when an infectious cause for SIRS is a concern, but no specific infection has been diagnosed, broad-spectrum antibiotics should be administered. Next, we have the corticosteroids. So these agents have anti-inflammatory properties and cause profound and varied metabolic effects. So next, we have antifungal systemic. Empiric antifungal therapy can be considered in patients who have already been treated with antibiotics. Lastly, we have the anti-diabetic agents like insulin therapy. For example, in patients with hyperglycemia. And steroids should also be considered in patients who meet criteria for SIRS. Then for the surgical management, patients with acute surgical issues like ruptured appendix, cholecystitis that causes SIRS should be treated with appropriate surgical measures. Like for example, the ruptured appendix surgical management is appendectomy. Cholecystitis surgical management is cholecystectomy. Ganun lang.
Today we will discuss the nursing responsibilities. So first nursing responsibility is to monitor for physiologic changes related to loss of vascular tone, like decreased blood pressure, bradycardia, tachypnea, reduced pulse pressure, anxiety, and oliguria. This is to evaluate response to treatment. And second is to place patient in a supine position with legs elevated to increase preload as appropriate. And lastly, monitor for signs and symptoms of hypovolemic shock, like increased thirst, increased heart rate, increased SVR, decreased urinary output, decreased bowel sounds, decreased peripheral perfusion, altered mental status, or altered respirations. And we will now proceed to nursing diagnosis. First nursing diagnosis is ineffective tissue perfusion, risk for infection, deficient fluid volume, risk for electrolytes imbalance, impaired gas exchange, and lastly is decreased cardiac output. So for the complications, there are different parts of our body that complicates when it has SIRS. First is the central or the brain, which is acute encephalopathy. For the respiratory, acute respiratory distress syndrome or ARDS. And acute aspiration pneumonitis related to encephalopathy. For the cardiac, demand perfusion mismatch causing troponin elevation and tachyarrhythmia. For the gastrointestinal, stress ulcer and acute transaminitis. For the renal, acute tubular necrosis and acute kidney injury, metabolic acidosis, electrolyte abnormalities. For the hematological, thrombocytosis or thrombocytopenia, disseminated intravascular coagulation, hemolysis, deep venous thrombosis, and lastly is for the endocrine, hyperglycemia, and acute adrenal insufficiency. That's all. Thank you for listening.